We start with the next speaker because we are running late. Dr. Jay Chordia. He is speaking on male infertility.
So very good morning. Rather, we have CMEs in the evening hours, so the first word comes as an evening. A very excellent talk by Dr. Gagan Priya pertaining to adrenal insufficiency. So slightly beneath, the adrenals are a very important gland for males, the testicular tissue. I will be discussing, definitely this is the morning time, and I think that I should not get you bored. A very important topic, basically because I hail from Udaipur. It is in Rajasthan, and Udaipur is a hub for infertility centers. You might be listening about Indra IVF. It has almost 108 chains in India now. So such big is a problem of infertility. When we talk about endocrinology, I think infertility is the biggest topic in endocrinology. So my presentation would be pertaining to a very important factor of male infertility. So when we define infertility, infertility is basically when a couple is having unprotected intercourse from almost a year, still they are not able to conceive. So the cause behind this may be a primary or a secondary infertility. When we talk about the incidence of infertility, because India is a male dominant society, so the males are not in front, only it is the female who is blamed for infertility until proved otherwise. But definitely when you see the incidences and prevalences, almost 20% to 30% of the cause of infertility is male infertility, and a rest is combination of female and male infertility. So you should always think when a female is not able to conceive despite all the hormonal profiles being normal, there might be a male factor behind it. And the very bad thing is that incidence of male infertility is increasing. You see from the background, and another eye opener for this is specifically pertaining to India. When we used to see our grandfather, grandmother, they used to hail around 4 or 5 children. Now we have single person children. So why so? Why the fertility at that point was good? Why the fertility at this point is bad? So when we talk about the Indian scenario, around 23% of the prevalence of infertility is because of the male infertility, and nearly 50% of infertility is related to certain reproductive anomalies, but other may be idiopathic. So it's very difficult to find a cause of infertility specifically for male and female. We have certain risk factors for male infertility. It may be local conditions, it may be environmental or lifestyle factors, it may be systemic conditions, and a multitude of hormonal causes. So whenever you think about male infertility, kindly focus on this very important slide. It can be from the origin, from the pituitary and the hypothalamic region, that may be a pre-testicular cause, it may be a testicular cause, it may be a post-testicular cause. The causes are in front of you. I will not read this because of the scarcity of time, but the very important thing is only keep these 3 points so that you will be more clear that which person needs a dedicated workup for infertility. A very bad point, what I am telling is that my grandfather had 5 kids, my nana also had 7 kids. But now what is happening? So this was the era of 1973. You see the sperm counts, and now this is the era of 2011, the sperm count. So that means average sperm count has fallen by 50% since 1973. What may be the cause behind? Why there was good fertility behind, and now we are suffering this infertility issue where we are having big infertility hubs? The huge amount of factors which play a role in this are these. Multiple factors responsible, maybe certain our bad habits, the sedentary lifestyles, the scrotal temperatures being high because of the tight clothing. This is all about the fashion, the physical activity, the caffeine, the anxiety and depression, the task-oriented work of our jobs. These all things come together, and then the other thing, we had celebrated the Earth Day. We don't prevent our environment. In the environment, we have certain endocrine disruptors. There are certain chemicals, there are certain disturbing things which disturb this, like air pollution, chemicals, and all these are basically very important for the viability of sperm, because sperm being a very sensitive thing, it is damaged by all these environmental factors. And the very biggest problem for today is this: the cell phones, the earphones, and multiple other things. Our lifestyle is now being clubbed by these all bad things, and this all electromagnetic field exposure from cell phones and multiple things may also lead to infertility. So we have to be more aware about our lifestyle also, about our sedentarism also, specifically not focus only on the hormonal aspects of treatment of infertility. So suppose the couple is now being diagnosed that okay, the male is the sufferer for infertility, how to evaluate and when to evaluate. So I have told you about that if they don't have a conception in a normal reproductive age after 12 months of regular intercourse, or if the female is say aged 35 years or so, then definitely you should think after 6 months for the couple, you should go for an infertility workup. A very, very important thing always missed in the day-to-day scenario is because we are busy practitioners, you don't have time to take the history, you don't have time to physical examination because this was a COVID pandemic time, we doesn't see the patient lively, we see from a distance. So then you can miss all this. You should take a proper history pertaining to infertility, that what was the duration of all that, the points are being mentioned. Then very, very important thing is about the sexual life, whether it is normal or not, both partners are satisfied or not. A medical history. In specifically medical history, you should have these certain points like cryptorchidism, the timing of puberty, certain anosmia or testicular trauma, or the very common point of mumps, orchitis, and these should be taken in the history, and then definitely the chronic diseases should come in play. Surgical history, any history of orchicopaxy or peritoneal or like that surgeries. Gonadotropin excision may be because of multitude of things, maybe on chemotherapy, maybe on hormonal therapies, maybe on environmental toxins. You never know, these things can disturb your gonadotropins, and definitely the family history of infertility. Cystic fibrosis is another very silent disorder which causes main infertility and androgen receptor deficiency. The foremost thing is, if you are thinking that a male is infertile, the first and the foremost thing you will take care of is a semen analysis. A very important thing, when I was coming from Udaipur to Delhi, I was reading an article where previously we used to have a concept that the semen should be collected immediately in the lab and it should be processed within an hour of collection. Now there are technologies available, because in the lab multiple of persons might not be comfortable. There are technologies where they can go for an home collection, and then there are certain kits now available. I don't think that in India it's still available. There are certain kits where they can just have a preliminary evidence that they are having a problem of sperm or not. So a single semen collection or a two semen connection, there is a certain issue between two societies, but I think on a safer side, distance apart, 48 hours of avoidance of intercourse, you can collect two semen analysis. Another very eye-opener slide, and this is a very important slide, definitely it is a somewhat older, because from 1980, WHO is giving a reference limit for semen analysis, and the last which was revised was 2010, and you see the sperm concentration, total sperm count, motility, vitality and morphology. From 1980, they have decreased the percentage of each. Say from sperm motility, it should, in the 1980 it was more than 60%, now it is only 32%. This is why? This is because our sperms are reducing. So the guidelines also say, and this is basically from the normal fertile males, this data is collected. There is certain question pertaining to WHO targeted semen analysis, but still you see that the normalcy factors have been reduced. This may be because of the decreased seminal counts or decreased semen counts. Then definitely for a sperm to fertilize, it should be normal. So you have certain terminologies where you have aspermia and then you have zoospermia combined together. There are multitude of disorders, from absence of sperm to poor and killed sperms to absent sperms to deadly sperms and teratozoospermia, then there are infective sperms and necrozoospermia. So these are the terminologies which are very important to just understand, because a laboratory may give you, and this is oligoasthenospermia. So you should have an idea that what it is all about. And when we think about this infertility issue, specifically in the seminal characters, the combined causes of asthenospermia, oligo and terato makes the majority causes of male infertility, and then the rest contributes their part also. When I was talking history, after that a very, very important thing is the physical examination. In endocrinology, the physical examination starts from the body habitus, the upper and the lower body segment, where you can just assess from the unicoid proportion that the male or the female is hypogonadic. then the fundus is important, the scrotum examination is important, and digital rectal examination is meant for the ejaculatory duct obstruction, where you can just assess the prostate size as well as the seminal vesicular mass or like that point of things. A very, very important thing, a male comes, semen is abnormal, the first and the foremost thing you will do is get a hormones done. Whether this male infertility workup is essential in all, and what are the tests you should get. So definitely endocrine testing is not meant for all males subjected to infertility. It is specifically for those who are having abnormal semen parameters, particularly when the sperm concentration are less than 10 million per ml, certain impaired sexual dysfunctions or clinical finding that suggest a specific endocrinopathy. Otherwise, you will land in trouble, you get your semen and you think that it is an endocrine issue and ultimately it doesn't come out to be anything. And these are certain terminologies which we use. Hypogonadotropic hypogonadism stands for from when the issue is from the pituitary or the hypothalamic part, then the testes are damaged, this is a primary testicular failure. There may be inconclusive findings. We don't have a cause behind male infertility, which is idiopathic, and then hyperprolactinemia via decrease of testosterone may play a role in infertility, a very, very important thing. So you have got your semen done, you have got your hormonal done, certain new test which I learned in the IVF centers in Udaipur, they are getting sperm DNA fragmentation, they are getting sperm quality test done, and I was just surprised at what this is all about. But this is important because 15% of cases of male infertility should be undergoing a genetic testing, specifically when you suspect a defective spermatogenesis, there is a resulting in severe oligozoospermia or azoospermia. It is crucial for diagnostics as well as you should not pass the same thing to your progeny. So the genetic testing for certain semen parameters are important. Specifically, we get a karyotype. This is the most important thing for a male as well as a female. The most common karyotype defect, definitely if infertility in male is there, is Klinefelter syndrome. Another very important thing which is missed is this Y chromosome microdeletion, which is indicated in patients with azoospermia or oligozoospermia and a sperm count of less than. Y chromosome microdeletion is a very, very important, almost 10 to 15% causes of male infertility, which we generally don't get on a day-to-day basis. Then another very, very important thing is the CFTR gene. With an allele, it should be tested. Why? Because a parent may be carrier for CFTR, and how it is diagnosed, basically there is an absence of vas deferens. So if the bilateral absence of vas deferens is there, you should think about cystic fibrosis. Both male and female should be worked. For cystic fibrosis, if one is there, kindly don't proceed with the same sperm or egg. DNA fragmentation doesn't need more discussion because these are more of a biochemical test, but very, very important in our scenario pertaining to IVF pregnancies, and done in those category of patients who are having clinical varicocele, unexplained infertility, in vitro infertilization failures, or borderline abnormal or normal serum parameters with risk factors. So certain category of patients are there fit for this category of test. And these are basically the methodologies of sperm DNA fragmentation, in which category of patient you get these special tests. I don't need to mention because it's very difficult for me to also learn all these specialties because these are more of a genetic test being involved. This is a WHO suggested algorithm for diagnosis of male infertility. So we have thought that the male is infertile, we get a history, physical examination, a semen, and if all come out to be normal, this is the end of male factors. But if there is any abnormality, definitely the referral should be there. But in India, a male infertility is being taken care by dermatologist also, urologist also, endocrinologist also, physician also. You don't know that who is taking care of a infertility. So you should have a proper referral, and definitely a very, very important scenario of approach to azoospermia. This is a beautiful slide where you see a azoospermic male, you see just get a karyotype and Y chromosome microdeletion plus hormonal evolution. If the vas is absent, you just get a CFTR. If vas is present, you go for a semen volume whether is normal or low. If it is normal, small testes, low FSH, hypogonadotropic hypogonadism, FSH high, primary testicular failure. Normal testes, normal volume semen, normal FSH, bulky epididymis and testicular biopsy. Think of obstructive azoospermia, go for scrotal exploration. A low volume semen, post ejaculate urine analysis, because this is another very common thing, retrograde ejaculation. If it is negative, then get a transrectal ultrasound to get all these possible things from obstruction to multiple of other pathologies. Gonadotropin treatment of male infertility, Very, very important, specifically for hypogonadotropic hypogonadism. You have a combination of FSH available, you have a combination of HCG and HMG available. So you can go for the gonadotropin replacement because, and then you also think about these various different parameters other than gonadotropin. You have SERMs like clomiphene, all that drugs. Then you have aromatase inhibitors also targeting at different points of this hormonal axis to go for your better semen quality. So we have clomiphene being commonly used as over the counter when you have an idiopathic infertility to improve the semen parameters. You have an aromatase inhibitors and definitely gonadotropin therapy. Pertaining to gonadotropin therapy, you have an option of GnRH pulsatile therapy. You have HCG, you have highly purified recombinant HCG. The dose is in front of you, and this is a very beautiful way to enhance fertility in hypogonadotropic hypogonadism, and the success rate within 6 to 12 months is very good. And this is pertaining to the hormonal dysfunction in the setting of infertility, a treatment, how you approach. You can just click on your camera because to read this is very difficult, but this slide is very important pertaining to in which category of patients you, after seeing the testosterone, you should go for aromatase inhibitor therapy, or you should go for SERMs, or you should go for the testosterone or that kind of therapy. Then you might have also listened about the various antioxidants being used in infertility, coenzyme Q, levocarnitine, multiple other things, whether they have a role. Definitely the reactive oxygen species play a role in harboring the quality of sperm. So if you want a good semen, you should focus also on this oxidative stress in male infertility, and definitely certain agents like vitamin C, levocarnitine, and coenzyme Q, and this was one of the trial basically pertaining to coenzyme Q supplement, zinc supplement, vitamin C, vitamin E. It may partially help pertaining to improvement of your semen quality. Then there is a word of anti-sperm antibody, not commonly being done, but you should do in certain category of patients which are in front of you, because certain patients who are having idiopathic infertility may harbor this anti-sperm antibodies also. Surgical options are another very important options. If you have a varicocele, clinically significant varicocele, I think varicocele, if it is being operated in a proper manner, you can have fertility in a normal way. So there are certain category of patients for surgical characters, like these are the basically the type of surgeries performed. Lifestyle changes, a very important thing. We are being driven by lifestyle. Husband and wife is sitting nearby, but they both are seeing their mobiles. They don't have time to discuss. They don't talk with the kids. So this lifestyle is what? And this basically harbors or gives you the stress of your infertility. So this should be taken care of. If I am in Udaipur as an IVF center hub, definitely we have good amount of centers which are doing this artificial reproduction technologies, and these artificial insemination by donors, these and surrogacies, you might have listened all this. So this is important, this is good, but the very important thing is that the person who is eligible for an IVF should go for IVF. It should not be until proved otherwise, because what I see in Udaipur, being doing an endocrine practice from last 12 years, I am seeing just the wife has came because the conception is not there, and when the husband is with him, with her, what I see, the husband appears to be classically euchinocoid. He is a case of mostly hypogonadotropic hypogonadism, but he is not taking care of himself. He doesn't want treatment because he is a male. So that is the problem. I say that the female is not at problem, you are at a problem. But he accepts that, sir, I will go for IVF, that's all. So they have found a simple way of IVFs. Rather, you should approach and you should treat, because the quality of life is very important. Future prospects are there in infertility, specifically the next generation genomic screening, and then there are very beautiful research pertaining to the role of small RNAs and microRNAs in epigenetic regulations, which may help to give you a better quality sperm, and this is basically more for IVF options rather than for normal scenarios. So if I need to summarize my presentation on male infertility, it is basically a global health problem. In half of the cases, a male factor may be partly responsible, so kindly, if an infertile couple walks in your chamber, ask the male also to get his semen done until proved otherwise, because this is not being done in a common scenario. From a medical perspective, the management of men with infertility failure, seeking fertility, it involves a series of steps. You should not rush ki aap mein lagta hai you get an FSH, testosterone and this prolactin done. Before that, kindly examine. It may be a varicocele, it may be an cryptorchidism, it may be unicoidism. So you have certain 50 to 60% of treatable causes of infertility, and 40% if not, then IVF centers are always there. Gonadotropin substitution should be properly educated, because this is not a short term therapy. At least you need a 6 to 12 months duration for gonadotropin to work. So it should be timely done, and definitely a coordinated multidisciplinary team is must. You may need a urologist help, you may need a surgeon help, you may need a genetist help, you may need a proper semen analysis, a pathologist help to be done. With this, a big thank you for your present hearing.
Thank you, Dr. Jay, for the beautiful coverage of a very difficult subject. Can we have some questions? Yeah, the audience can get clarification from both the speakers if they wish.
Yes, you want to ask something?
Yeah,
Yes, ma'am.
you are allowed. Yeah, please.
How many cases per speaker has seen cases of adrenal insufficiency in our practice? Say once a week or twice a week.
Gagan is not there.
Dr. Gagan, please.
I think Gagan has just left the hall, but I think in endocrinology, sir, if I am an endocrinologist, the Delhi persons are sitting with me, adrenal insufficiency is a hidden problem. But definitely there are good amount of incidences. I can't say that on a daily basis how much patients you see for diabetes or thyroid, you will see the adrenal insufficiency patient, but there are hidden patients of adrenal insufficiency who just are getting treated by gastroenterologists for decreased appetite, by dermatologists for blackening of skin. But if I quote the percentage, it is very difficult. It may be, I think, 2%, 5% of our population, but still adrenal insufficiency is a silent issue, but it is common, sir.
Yes, Dr. Verma, please.
Thank you, sir.
What I do in male infertility is, sir, first of all, we should do the first step should be to test the semen germination.
Yes.
Then we should go to the lady. What we are doing is, because they come with the problem that the lady is having some problem, male they will attend to. So we should do first semen germination, we should exclude, then go to the female test.
Yes. If we talk about, that's why I was telling you, sir, this is a male predominant society. The males are always second targets, only the female is the first target. But if I talk about male infertility, and if I suspect that there is a male factor, the first and the foremost test, I will not go for hormonal evaluation also. The first and the foremost test is definitely a physical examination, a history, followed by a semen analysis. Because semen analysis, if it is normal, the majority of the chunk is ruled out pertaining to the male factor. But still, if you are very much suspicious, then you can get the hormonal test done if you have a normal semen parameters. Very point. Yes, ma'am.
Yes, Dr. Satish.
Yes, ma'am. Mic, you can use it.
I'll speak loudly. If on semen analysis we see pus cells, do you treat for it like hexanucleosides in the semen? So is there a role for any antibiotic treatment for this, and does it help?
Very, very beautiful point, and a missed point basically. I rather appreciate for your point. A very, very important cause of infertility is the genital infections or the urogenital infections or the prostatic infections in the male. It may be long-term prostatitis, it may be epididymitis. The most common agent behind this is Neisseria and chlamydia before the age of 35 years. So if a young male is there, the most common two toxic pathogens who are causing this pus presence in the sperm is Neisseria and chlamydia. After 35, it is E. coli, which is the majority of the chunk causing abnormal pyospermia. So if you see any pus cells in the semen, the very important thing is this is just infective cause by which the semen quality is poor, because sperm is very sensitive for any damage. So you just have to treat it via proper antibiotics, at least for a span of say 15 days, prolonged to 30 days. With this antibiotic, you have to repeat a sperm count, say after a span, once the patient is asymptomatic, after a span of 1 month, you get again a semen analysis, and if that is cleared and still the semen abnormalities are then you should think of other causes. Otherwise, proper antibiotics, proper treatment of prostatitis, proper treatment of this infection will definitely help to get you multiple of hormones test being done. So we miss generally this in our day-to-day setting, and definitely infection should be taken care of. Semen analysis, I think basically there is a difference. The label is at, because these are all now digital things to be taken care of. The machine just gives a reading that this is the amount of pus cell. There is no any specific cutoff, but definitely pus in semen is abnormal. And what the label is, a round cell or a pus cell. A round cell may be a germinome also. So you have to just segregate whether it is pus or whether it is a round cell. And on the pus cell, I am not much aware about the cutoff, but definitely any pus or any infection in the semen itself is abnormal. You have to get a semen culture also done in certain scenarios, which may give you a proper antibiotic cover.
Yes, Dr. Chuk, please.
Sir, mine is a observation, comment and your opinion also. In periphery, I am practicing for the last more than 45 years.
Yes, sir.
And there are many persons, young boys who are just married and they are having complete azoospermia. And once I say, sorry, you have to do something more. And the very next year, the couple comes with the child in their lap. And one of them, they commented, Doctor Sahab, aap to keh rahe the, bachcha nahi hoga, mera to bachcha ho gaya saal ke baad hi. So this is what I am observing. This is probably some neokriya they are adopting or something more. You should comment upon it, please. Thank you.
Great. A very, very important thing, sir. Very, very beautiful point. जब भी आप एक इनफर्टाइल, मैं हिंदी में बोलता हूँ सर, कि जब भी आप एक इनफर्टाइल कपल को देखें, भले वो फीमेल हो भले वो मेल हो, कभी ये ना बोलें कि तुम्हारे बच्चा नहीं होगा. सो नेगेटिव थिंग शुड नेवर बी देयर, बिकॉज क्या होता है जो आप बोले ना वो होता है, कि वो एक बच्चा लेके आ जाते हैं, बोले आपने तो बोला तो बच्चा ही नहीं होगा. सो यू नेवर नो कि गॉड कब एक स्पर्म किसी में निकालता है. एंड दिस इज माई प्रैक्टिकल एक्सपीरियंस ऑल्सो. आई हैव सीन अ क्लाइनफिल्टर सिंड्रोम मेल who developed, who rather got conceived in a normal word. There was a complete azoospermia. Then kahan se wo sperm aayi, you never know. For a female, I had seen primary ovarian failure. She was in Bhiwadi only, and she visited me in Udaipur at an IVF center, referred me for prolactin issues, but she had primary testicular failure. She was taking an egg on donation part, and suddenly just I gave her estrogen. मैंने कहा आप IVF के लिए तो सोचो, अभी तो अपना estrogen तो कम से कम लो क्योंकि आप यंग हो. Estrogen दे के छोड़ा और 3 महीने बाद उसने फ़ोन किया कि सर मैं तो कंसीव हो गई. So you never know where an egg comes, where an sperm comes. So definitely medical science is full of surprises. So azoospermic males may conceive, a female with primary ovarian failure may conceive, but definitely this incidence is very, very low. हमारी टेक्स्ट बुक्स में भी लिखा है शायद करोड़ों में एक या लाखों में एक हो सकता है.
Thank you.
Mine is a very unusual case, maybe an eye-opener to people. I am Professor Kalra, formerly Professor of Medicine, FMC Pune.
Sir.
I was the examiner for MD. There one of the examiners on one side car took me. He said, Doctor Sahab, I want your advice. I can't have sex with my wife.
Okay.
When I go for it, I am miserable. I develop pain in my both groins and 2 days I am out. Very unusual thing. What to give explanation? Maybe prostatitis you have got. Many things thought. I just think check up kara lo, get to urologist. He was being investigated. Meantime, I saw another case. Mother came to me. My son is 29 years age. He is not marrying. He has come from New Zealand. You are treating me for diabetes, hypertension. I want you to please tell him. Hey, I am calling you for your mother's sake. And then you ask, how is your family and how are you living? So that fellow said in very silent way, sir, I don't want to marry. When I have sex with my girlfriend, I am miserable. I can't be comfortable for 2 days. So same thing, I thought prostatitis and sent to the urologist. He gave doxycycline for 1 month, came back to me. कोई फायदा नहीं हुआ. I got usual investigation. He himself suggested me, sir, मेरा vitamin D करवा देंगे? I said, okay. Got vitamin D, it was 4 nanogram per ml. I started him on 60,000 units. After 1 week he says, sir, मैं इसको हर हफ्ते ले सकता हूँ. I said, ले लो. And later on, this fellow got married, he was all right. Now, what is the reason that vitamin D causing this problem? Same thing happened to that professor who had consulted me. Doctor Sahab, ये vitamin D miracle है. I have become all right. Now, I don't know explanation as a teacher myself. So you are expert on this.
Sir.
Tell me how vitamin D improved that one.
Vitamin D, I think, is more of a fancy vitamin now rather than, because the majority of my patients also come and give me an explanation कि सर मेरा vitamin D B12 करा लीजिए. So this is such a rampant problem. I don't know how we are having this problem. Vitamin D is a pleiotropic hormone. It is a pleiotropic hormone, means it is a pain reliever also. It may be an infertility expert also. It may be a bone regenerator also. So you never know. It is a subjective thing. Basically, to take care कि vitamin D देने से सब कुछ ठीक हो जाए, वो संभव नहीं. But definitely vitamin D, being a pleiotropic hormone, has its own play, and it is important, and it should be replaced. Yes.
Thank you, Dr. Jay,
Thank you, sir.
and thank you everybody for nice presentation. Thank you.